The body needs oxygen for cellular energy and survival. The byproduct of this process is not only ATP but also carbon dioxide. Based on the Henderson-Hasselbalch equation, carbon dioxide is a volatile acid which needs to be regulated to maintain normal body pH. The respiratory system regulates both oxygen and carbon dioxide through alveolar ventilation, which is the volume of air per minute that reaches the alveoli and participates in gas exchange. Several factors affect alveolar ventilation or VA. As shown by this equation, a decrease in tidal volume or TV, a decrease in respiratory rate or RR, and an increase in physiologic dead space ventilation or VD. Cause low alveolar ventilation, leading to hypoxemia and hypercapnia. During hypoxemia and hypercapnia, the greater demand for oxygen intake and carbon dioxide expulsion is sensed by the medulla that houses the respiratory central pattern generator or CPG. This controls the automatic rhythm of ventilation by responding to inputs coming from the central and peripheral chemoreceptors. The central chemoreceptors are sensitive to hydrogen concentration in the CSF and brain interstitial fluid induced by changes in the arterial carbon dioxide tension, while the peripheral chemoreceptors are mainly sensitive to a decrease in oxygen tension and slightly to an increase in carbon dioxide tension and decrease in pH. For example, a decrease in alveolar ventilation leading to hypoxemia and hypercapnia stimulates the peripheral and central chemoreceptors. These chemoreceptors would then send signals and command the CPG to increase minute ventilation or VE. By stimulating the muscles of inspiration and expiration, which increases TV or RR. As a result of deep rapid breathing that increases VE. The low alveolar ventilation and initial hypercapnia are partially corrected. What is VQ matching? It is the relationship of the ventilation or V with its perfusion or blood flow or Q in a respiratory unit or RU. There are 5 types of VQ relationships. First is the ideal VQ or VQ ratio of 1, wherein the RU receives equal amounts of ventilation and perfusion. Hence, there is optimal gas exchange between the alveolar gas and pulmonary capillary blood. For example, an RU receives 3 LPM of ventilation and 3 LPM of perfusion. Then, the VQ ratio is 3/3 or equal to 1. On the other hand, low VQ or zero VQ are states of hypoventilation wherein there is low oxygen tension and high carbon dioxide tension. In a low VQ, the RU receives inappropriately low ventilation relative to its perfusion, just like when an RU receives 2 LPM of ventilation and 3 LPM of perfusion. Then, the VQ ratio is 2/3 or less than 1. In this case, not all blood flowing into the RU is allowed to undergo gas exchange. This is known as alveolar shunt. This type of VQ is pathologically exemplified in asthma. In a zero VQ, the RU receives no ventilation but perfusion remains normal, just like when an RU receives 0 LPM of ventilation and 3 LPM of perfusion. Then the VQ ratio is 0/3 or equal to 0. In this case, blood flowing to the RU is not allowed to undergo gas exchange simply because there is no gas to exchange with. This is known as true alveolar shunt. This type of VQ is pathologically exemplified in alveolar edema. In contrast, high VQ or VQ ratio of infinity are states of hyperventilation, wherein there is high oxygen tension and low carbon dioxide tension. In a high VQ, the RU receives inappropriately low perfusion relative to its ventilation, just like when an RU receives 3 LPM of ventilation and 2 LPM of perfusion. Then, the VQ ratio is 3/2 or greater than 1. In this case, the excess volume of air will not be able to have any gas exchange. In VQ of infinity, the RU receives no perfusion, just like when an RU receives 3 LPM of ventilation and 0 LPM of perfusion. Then, the VQ ratio is equal to infinity. In this case, the air in the RU is not able to have any gas exchange with the pulmonary capillary blood. In both hyperventilated VQ states, The act of ventilating an RU has the same effect as ventilating an anatomic dead space, wherein no gas exchange occurs. This is known as alveolar dead space. It is significant since it contributes to the physiologic dead space. Pathologically, hyperventilated VQ states are exemplified in partial or complete pulmonary embolism, wherein there is increased physiologic dead space that decreases alveolar ventilation. Knowing the different VQ ratios is important since the VQ ratio of the lungs is not the same throughout. This dissimilarity is attributed to the effect of gravity. Graphically representing the VQ relationship in the different lung zones, the x-axis serves as the rib number, starting from the lower ribs or from the base of the lungs, moving up to the upper ribs or to the apex of the lungs. On the other hand, the y-axis represents the VQ ratio. Although gravity affects both ventilation and perfusion, the effects are more pronounced in perfusion. The lower lung zone is 3 times better ventilated than the upper lung zone as seen in the graph as a gradual downward slope. However, the lower lung zone is 8 times better perfused than the upper lung zone as seen in the graph as a steep downward slope. In effect, the lower lung zone at rib 5 has a higher perfusion value of 1.9 than its ventilation value of 1.3. This results to a VQ value of 0.7. On the other hand, the upper lung zone at rib 2 has a lower perfusion value of 0.4 than its ventilation value of 0.8. This results to a VQ value of 2. In summary, due to the regional differences in an upright lung, VQ relationships are arranged in gradations where the upper lung zones have a high VQ promoting alveolar dead space. The middle lung zones have an ideal VQ and the lower lung zones have a low VQ exhibiting alveolar shunt effect. Due to this, the lower lung zone will have low oxygen and high carbon dioxide tensions, while the upper lung zone will have a high oxygen and low carbon dioxide tensions. In pathological conditions, the normal VQ relationship is altered. Examples include pulmonary embolism, pulmonary edema, pulmonary fibrosis, and COPD that encompasses chronic bronchitis and emphysema. Now, let us discuss the consequences of this altered VQ relationship. In an RU, the ventilation is dependent on compliance and airway resistance. Compliance is directly proportional to ventilation, while resistance is inversely proportional to ventilation. A decrease in compliance results to a decrease in ventilation, while an increase in resistance results to a decrease in ventilation. In asthma, there is increased contraction of smooth muscles in the bronchioles, which increases the resistance and decreases the ventilation. Since the lungs are composed of millions of interconnected respiratory units, a single respiratory unit affected by a disease can affect the other respiratory units by diverting the ventilation that is supposed to be for the diseased respiratory unit to the normal respiratory unit. This low VQ results to an increase in alveolar shunting, which eventually gives rise to a secondary high VQ or alveolar dead space. In asthmatic patients with an obstruction on the right bronchial airway, the perfusion will be equally distributed while the ventilation will be unevenly distributed, favoring higher ventilation on the normal left lung. Consequently, the left lung will have a high VQ while the right lung will have a low VQ. Thus, the lungs are composed of RUs with low and high VQ. This state is known as VQ mismatching. Going back to this equation, due to VQ mismatching, physiologic dead space ventilation increases, which diminishes VA dot, leading to hypoxemia and hypercapnia that stimulate the respiratory control. This results to a compensatory increase in minute ventilation.